Welcome to our podcast, Neurology Morning Commute, getting up to speed on multiple sclerosis management. Morning Commute is developed in collaboration with At Point of Care and Projects and Knowledge and is part of a continuing medical education series. This independent CME CE activity is supported by an educational grant from Bristol Myers Squibb. Over the past several decades, treatments for multiple sclerosis have evolved from virtually none before 1993 to a plethora of choices now. Dr. James Bowen and Dr. Jeannie Cote look at the array of treatment options and how to choose the best ones for MS patients. Information about the faculty and disclosures can be found at morningcommutepodcast.com/MS7. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Bowen is the Medical Director of the Multiple Sclerosis Center at Swedish Neuroscience Institute in Seattle. Dr. Cote is a neurologist at the Multiple Sclerosis Center at the Memorial Healthcare Institute for Neuroscience in Owasso, Michigan. I am Candace Hoffman, Managing Editor of Morning Commute. Dr. Bowen will begin our discussion.
Welcome to our podcast, Neurology Morning Commute. Today, we'll be talking about getting up to speed on MS management. I'm James Bowen, the Medical Director of the Multiple Sclerosis Center at Swedish Neuroscience Institute. I'm joined by Dr. Jeannie Cote, a neurologist at the Multiple Sclerosis Center at the Memorial Healthcare Institute for Neuroscience in Owasso, Michigan. Dr. Cote, thanks for joining me today.
Thank you for having me. I'm looking forward to participating in this today.
Let's start our discussion by taking a 30,000-foot view of the current treatment landscape for MS. We've come a long way for the treatment of this chronic disease. When I first started, there were no treatments for MS. It was a very simple field, but we got our first treatment in 1993, which was interferon beta-1b. And then as far as early injectables go, we have now 4 different types of interferon. We've got glatiramer acetate as well as generics for that. And also in the injectable, there was a new one added in 2020, ofatumumab. We started having intravenous infusions in 2000 when mitoxantrone came out, which was also the first drug approved for what back then was called chronic progressive MS. We started getting intravenous treatments available in 2000 when mitoxantrone was added. This was the first drug approved for a progressive form of MS. Back then it was called chronic progressive MS. Natalizumab was added in 2004, and then later in 2014, alemtuzumab, and most recently, ocrelizumab in 2017. Oral options are now available with the sphingosine-1 phosphate modulator, first started in 2010 with fingolimod. We now have 4 members of that family. We have teriflunomide added in 2012. And fumarates added in 2013 with now 3 fumarates on the market. Finally, there's oral cladribine, which was added in 2019. So we have quite a large number of medications that have been added in the last few years for this treatment. So Dr. Cote, sticking with our 30,000-foot view, maybe you can discuss with us sort of how you view how to go about picking the right therapy for a patient with MS.
I'm happy to. You know, it's funny to hear you list all of them. It really is impressive at how many therapeutic options we've really been able to really have access to now over the last few decades. You know, when patients come in, it really just starts with, a conversation about their journey with MS so far. What have their presenting symptoms been? What type of symptoms are they coming in to see me with as far as any residual disability? And that sort of helps, I think, them get a sense of how much risk they're willing to accept related to treatment and what they're prioritizing out of treatment. Because I might think a drug is perfect for a patient, but if they're not committed to going down that path with me, we're not going to get very far. So really a lot of it is first just learning how MS has affected them and what they're really prioritizing as far as what they want out of treatment and how much risk they're willing to accept from a treatment. And then my job is to really take a look at the treatments available, the data that we have on them, and see, are there clues about a patient's case that make me favor one treatment more than another? And can I find a treatment that works within their risk tolerance and kind of matches what they're prioritizing out of treatment? So some patients might say, 20 years from now, I want to be able to walk my daughter down an aisle. Or a patient might say, no matter what, I don't ever want to face PML, which is, a brain infection that we rarely see out of our treatments. And so a part of it is really just meeting the patient halfway. And then part of it is really using the data from the trials and just from regular use of practice with these medicines and seeing how they've worked in real patients in real time to find the right treatment. And other things that I think we'll talk about a bit later might be things like other health conditions and, age and other kind of prognostic factors. But really, it starts with a blend of what the patient's looking for and what I'm hoping to achieve for them.
Yeah, I think this is, it's very challenging because I think we have a similar approach here where we don't really have a favorite drug. It's you really have to get to know your patient and where they're coming from and what they value. Do they want higher efficacy? Or are they worried about certain side effects? So sounds like we both spend a lot of time just getting to know them and understanding where they view the risk and the benefit.
What I do find, though, in general, that does not work well, and I still see this done quite a bit, is I'll ask a patient who's been on treatment in the past, how was this treatment chosen for you? Was it something you asked for? Were you told to take it? What was the conversation that led to this treatment being chosen? Because it really helps me get a sense of how a patient thinks about a treatment or maybe how educated they are in the process of treatment selection. And often I'll hear, I was given a pamphlet or a booklet and I was told to pick. And, there are so many treatments that you listed, and there's so much to know about these treatments. And for people who do this on a regular basis, it's overwhelming to put your arms around how many therapeutic options we have. And so I think to ask a patient to pick from a pamphlet with this level of option really is no longer really something that I think we should be doing as providers. I think we really do have to work with that patient to narrow down those options and really guide them at this stage in the game.
Yeah, I would totally agree with what you just said. The ones that get the starter kits and read these 3 starter kits and let me know what you want, they really don't have the buy-in for that drug, and they're not as adherent over time as a result. So, yeah, I think it takes a lot of time with the patient, and it's difficult to just circumvent that by saying, go do your own homework given this material. So I'm glad to hear you do it similar to us.
Although I will say, I will give patients some literature and say, make it a date night, take a weekend. This is your homework. We'll circle back in a few days to answer questions. And it may take a couple conversations, but I think the more confident they are with the plan early on, the less bumps in the road you're going to get, in the long run, obviously.
Yeah, I would agree. And it's worthwhile taking a little bit of time up front to get it right, rather than rushing the decision and maybe having them not have full buy-in in that decision.
The other thing I do like to tell patients is, these are important decisions to make, but we're never also locked in to a treatment. There's always an opportunity to change course, and it's important to make decisions, but these decisions aren't forever decisions. So as overwhelming as it can feel sometimes to say, what's the right treatment for a patient, there's a lot of surveillance that goes in after that decision's made that really helps, reaffirm if we're on the right path or not. So I think starting with something is important, but also knowing that that something isn't a forever choice and that there's always flexibility to come at this a different way, really, I think helps patients also feel more comfortable taking these medications and kind of trusting me to help guide them.
How much does side effects play into to your thinking on this? Because I know you're an MS specialist and use all the drugs, but the doctor also has to be comfortable, and side effects are probably where the big pressure point for the neurologist is.
Yes. I wonder if having trained in an era where all of these were really part of the normal landscape and not new innovation after innovation, over the years, my fellowship was at a time where we were using alemtuzumab and using B-cell, modulating agents. So to me, this was sort of the normal, kind of normal surroundings to use these types of medications. It wasn't that I had only had platform therapies and now these new innovations came and I had to really kind of decide how much risk I wanted to take using these medications. It was sort of my stomping ground was to use them. And having a parent with MS who has been on a variety of medications over years, I think also just gave me a really different experience of seeing what a patient's experience on these different medicines and what side effects really could look like, both from, what I perceive a loved one going through and what they're reporting as potential side effects. And so for me, in general, I feel like we can make any medication work. And in general, I think these are incredibly well tolerated across the board. And while every medication has a unique side effect profile, in general, I always feel that undertreated and untreated MS comes with so much more side effect than appropriate and safe, responsible use of these medications. And I feel that 100 times over. We can use these medicines in general. They're incredibly well tolerated. I can usually always find a good fit for a patient. Extreme side effects where I really had to step in and manage major complications is incredibly rare for the, many, many, many patients that I see. So in general, to me, the bigger side effect is undertreated MS always.
Yeah, there's definitely been a shift toward being more aggressive in our treatment. I might also comment about just adherence. And, back in former days when we only had a few options, I think adherence was a much bigger problem. It's still a problem, but nowadays we can often shift treatments to address whatever the reason for the adherence was. So, some examples of that would be like, moving away from the injectables toward oral or intravenous medications is often a good option to improve adherence, particularly some of the infrequent injections. With the intravenous infusions, when the patient got infused and when they're late for their next infusion. Also, we're able to shift around. If they have one side effect they didn't like, we can shift to something else that doesn't have that side effect. And just having more choices to switch to, I think, has made a real difference. One other factor about adherence is some of these medications have long-lasting effects on the immune system. And that can be a negative because the effects are long-lasting, but it can also be a positive because it smooths out adherence problems and allows people to maintain their immune treatment, even maybe if they're a little bit late on getting their next treatment. I assume you've noticed several things like that in your practice.
I think the patients, for some of them, have really loved the freedom of not having to think about having MS every time they take a daily treatment. So interrupted treatments have really, I think, given some patients peace of mind. Others really love the security of a daily treatment. So it's just really nice to have options that meet the needs of all patients.
And then how do you, when you're individualizing this treatment, how do you take into account various disease factors that might predict who needs more aggressive treatment or less aggressive treatment? What sort of factors do you think about?
So I'm absolutely looking at, first and foremost, probably what their clinical and radiologic kind of course look like. So how frequent are the relapses now that we know that they have MS, especially that, in the beginning stages? Where are their attacks happening? Are these primarily optic nerve, spinal cord, or cerebellar? So if I'm seeing someone who has a lot of spinal cord or infratentorial burden, I worry about their reserve, and I think that they have less wiggle room to tolerate more hits to the system. And I want to come out with a very, strong treatment that's not going to leave much room for breakthrough relapse. If they've been on other treatments before, that might influence where I want to go next. If someone's breaking through a medicine, I'll want to move to a higher efficacy, versus if it's a tolerability issue, then I might be looking at a lateral efficacy move. And then things like age or other health conditions could influence. Medications can influence as well. If someone's on a certain cardiac regimen, that's going to take priority. I have lots of MS options, treatment-wise, that I could be using. Mm-hmm. So, there's a lot that kind of factors into the decision-making. But for me, first and foremost, it's going to be the symptoms, the level of disability, and the MRI findings to help me know how much reserve I'm estimating that they have and how much wiggle room we have moving forward.
Right. Yeah, I use a similar set of demographic and MRI and disease characteristic findings. I reviewed this a couple of years ago, and I was surprised, even though we think about all these factors, that they're not real strong predictors of bad or less bad disease. And the one factor that's probably the strongest that we could also emphasize with our listeners is that the best prognostic indicator is whether they're continuing to have disease activity after you start them on treatment. So, just a plug for people to keep monitoring their patients.
I 1,000% agree. I think the one thing that I see repeated again and again are patients coming to clinic and their last MRI was a decade ago because they had been feeling well. Mm-hmm. And if you're keeping careful watch, it's hard for major things to get away from you. Even if someone feels well, that is wonderful, but I don't trust that. I want to verify with imaging, an exam, whatever I have at my disposal to evaluate, to really try to be confident that we are doing the best we can at this stage.
And obviously you would escalate if they're having new activity, but do you have some sort of guidelines that you follow, or your own personal views of when to escalate treatment?
So I think easiest is obviously if there's breakthrough disease activity, on a therapy, then I want to escalate, whether that's active or expanding lesions on an MRI or a new clinical relapse that I'm really convinced is related to breakthrough disease and not, urinary tract infection or something. But we also spend a lot of time talking about listening for the whispers of progression. So, sometimes it's not so obvious, and I'll carefully sort of review my past few notes to look for serial changes on exam or ways patients have worded things that have suggested continued creep of change. And more, I'm also really starting to make changes in that context as well. So both kind of the obvious, but even the subtle is starting, for me at least, to be a talking point about, are we using the right treatment?
And then one hot topic these days is whether you start out with lower efficacy drugs and escalate if patients have more attacks, or whether you just start out with a high efficacy drug from the beginning that may have more side effects. And how do you think about that? And how do we decide how to start the treatment?
So I am in the camp of early high efficacy for most patients who are coming to me new diagnosis. Mm-hmm. And I think part of that, is I do take into consideration my mom's journey. She was given the best therapies at that time and has a, significant level of disability at this point. And so part of it is I don't want to do the same thing. And I, trained in an era of high efficacy medicines, and I want to see if we use those more readily and more quickly, what we get. And I think there's a lot of studies that have really shown early use, will delay EDSS changes and accumulated disability and MRI metrics. And this has been looked at in many different ways. And I think there are clues that this will change the future landscape. That said, is it appropriate for everybody? No. But I think for the vast majority of my new diagnoses with inflammatory disease, I tend to lean towards early use of a high efficacy therapy. I'm not sure how you are with your practice, but at least over in Michigan, that's what I'm doing.
Yeah, I think more and more we are comfortable with early aggressive treatment. And I thought I would point out there are two studies that we're all anxiously awaiting the results on, but one is Treat MS, where people are randomly assigned to these two treatment options, early aggressive or early standard treatment. And the results from that study should be available at the end of next year, so the end of 2023. There's also Deliver MS, where they are, again, similarly looking at early aggressive versus standard treatment. And they're looking more at brain volume, and that study will not be available, or the results will not be available till the end of 2026, so 4 more years from now. I think I will move on to the last topic, and that's a lot of people have questioned like the ultimate in aggressive treatment, which is hematopoietic stem cell transplants. This is it's like the old bone marrow transplants, except it's stem cells, not bone marrow, that they're transplanting. And I've been heavily involved in this for several years. And it looks like from phase 2 studies that this may an extremely aggressive treatment may be very effective at slowing or stopping MS activity, especially in people with relapsing, remitting multiple sclerosis. We've gone as far as phase 2 studies, and so now just recently a phase 3 study called Beat MS is underway and is now recruiting. They're taking people and randomly assigning them to either a transplant or aggressive treatment with standard treatments. This would be cladribine, natalizumab, alemtuzumab, ocrelizumab, ofatumumab, or rituximab. So all the MABs plus cladribine. And they have to have 2 attacks in the last 36 months to get into the study. At least one of those has to be on an oral or IV treatment. So they're failing aggressive treatment before they go into this. And the plan is to follow them for 6 years and see what the outcomes are at the end of that time. So I don't know if your patients are having questions about those types of aggressive treatments, but this is probably the one that's will at least answer the question whether ultra aggressive treatment is going to be useful.
Oh, yes. It comes up almost every day. So I'm really looking forward to getting some more clarity on how hard we should be advocating for this.
Yeah. Yeah, the study itself has been slow getting out of the starting blocks because of COVID, but most of the sites are now starting to ramp up now that this current wave has subsided. So hopefully we'll get some good data coming out soon.
Great.
So this has been a great discussion. Dr. Cote, I'd like to thank you for joining me in this. In our next podcast, we'll be specifically looking at 2nd-generation sphingosine 1-phosphate receptor modulators. So I hope you're able to join us for that.
Remember, to receive your credit and evaluate this program, please visit morningcommutepodcast.com/MS7. Look for all of our podcasts on your favorite podcast streaming services. Thank you for joining us today.